So as you can see today, the lecture is on Ischemic Heart Diseases or IHD. The chapter name in your KDT is Anti-Anginal Drugs. So we'll go through the types of angina, the drugs used, the classification. There are two types of classification. One is a clinical classification and one is the pharmacological classification. We'll go through each of the drugs, the PKPD of each of those drugs, the adverse drug reactions, a little bit on peripheral vascular diseases and the device management for treating a patient with MI. So what can you see in this picture? A patient grasping his left-sided chest. What does it refer to? Generally left-sided chest pain or angina. It could be chest pain, chest tightness or pain in the back. Also sometimes due to the patient might complain of indigestion or abdominal discomfort. So what does angina feel like? It can be a chest pain, generally left-sided, but it can be happen in both the sides. Chest pressure or as they call squeezing sensation in the chest or chest tightness, heaviness in the chest, all these symptoms can occur. Also sometimes the patient complains of indigestion. The patient complains of bloating or feeling nauseous, but sometimes it's because of underlying IHD or ischemic heart disease. Sometimes the anginal pain can spread to the neck, the back and also to the jaws and the arms, mainly on the left-sided arm pain. So, angina pectoris is the principal symptom for IHD, characterized by sudden severe substernal pain or pressure. The primary cause of angina is an imbalance between the myocardial oxygen demand and the oxygen supplied by the coronary vessel. So, it's a problem between the demand and the supply of oxygen in the myocardial tissue. The imbalance may be due to a decrease in myocardial oxygen delivery. What are the causes where myocardial oxygen delivery is decreased? Maybe it can be because of vasoconstriction, coronary vasoconstriction, so leading to decreased supply of blood, or it can be because of a atherosclerosis, a plaque or a thrombus or an emboli. It could be due to an increase in myocardial oxygen demand, where this situation arises mainly because of stress or exercise, and you have seen most of the times angina precipitates because of exercise or a stress, or it can be related to both. This photo shows a plaque in a coronary artery. So, there is insufficient blood flow to the heart muscle from narrowing of the coronary artery, and this leads to development of chest pain or angina. Now, it occurs when becomes narrowed by atherosclerosis. If you see, look at the photo, there is narrowing of the blood vessel because of deposition of cholesterol buildup or plaque, or it could be a recently moved emboli or a thrombus which is dislodged, and there is development of platelets. Platelet aggregation happens at this site. So, there is narrowing of the blood vessel. Blood flow through the arteries or the veins decreases. So, it occurs when the coronary arteries becomes narrowed by atherosclerosis, that they are unable to deliver sufficient blood to the heart muscle. Localized areas of thickened tunica intima with accumulation of smooth muscle cells and lipids principally, as you see in this picture. So, example, it could lead to angina or angina pectoris. It could lead to myocardial ischemia, which is reversible, or it could lead to myocardial infarction. What is the difference between these three? Angina, myocardial ischemia and myocardial infarction. Okay, we'll see in the next slide. Angina is basically the symptom or the pain. It's episodic reversible oxygen insufficiency. Severe chest pain radiating to the left shoulder and down the inner side of the arm. Sometimes it can refer to the back, to the neck, to the jaws, etc. So, it's usually precipitated by physical exertion or emotional stress. What is myocardial ischemia? Deprivation of oxygen to a portion of the myocardium which is reversible for a short duration of time. When does it turn into infarction? When the ischemia or deprivation of oxygen is on a longer period, it can lead to infarction. It's a severe prolonged deprivation of oxygen to a portion of the myocardium that leads to its necrosis. So, if it's happening for one-time event which is reversible, it can cause ischemia. But if it's prolonged or long-term, it can lead to infarction leading to necrosis. Reasons, again, etiology, decreased blood flow or increase in oxygen demand or both. Firstly, decreased blood flow causes atherosclerosis is the most common cause. Next is coronary artery spasm, sustained contraction of one or more coronary arteries leading to decrease in blood supply. This type of etiology or cause of angina is called as Prinzmetal angina, or it could be because of myocardial infarction as well. We'll see one of those slides, a photo where we can distinguish between the two. It could be related to a traumatic injury where there is interference with the blood flow to the heart, or emboli events can abruptly restrict the oxygen supply. Emboli dislodged from maybe PVD or somewhere else, a thrombus coming and the emboli blocking the coronary artery leading to stoppage of blood flow or decrease in blood flow leading to ischemia and then infarction. Increased oxygen demand is generally due to exertion or emotional stress leading to sympathetic stimulation. Increase in heart rate also decreased blood flow into the coronary vessels. Reduced blood oxygenation, reduced oxygen carrying capacity during anemia. In a patient with anemia due to decreased oxygen carrying capacity, it might lead to a infarction. Risk factors, again, the lifestyle factors like smoking, leading to increase in heart rate, hypertension, diabetes mellitus, males above 45 years of age or females above 55 years of age. But at the same time, nowadays, MI or angina can happen in late 30s or even late 20s as well. Dyslipidemia is a big risk factor because dyslipidemia leads to increase in cholesterol buildup, can lead to atherosclerosis. Family history of coronary artery disease and others like sedentary lifestyle and history of any chronic inflammation. And this is a photo of the global map showing the incidence of CAD or IHD across the world. The green area showing low, orange, moderate, and the red is high incidence. India comes in one of those high incidence of IHD or CAD factors across globally, along with the developed nations. Now, angina are mainly, this is what could be asked during your Viva as well. Angina are mainly of three types. The first and the most common is the stable angina, or known as, also called the classical angina or atherosclerotic angina or exertional angina. What happens in this? It's developed generally after exertion or stress, or even after meals, and lasts generally less than 5 minutes. What happens if you see at this photo, there is a atherosclerosis in this coronary artery. Now, in between the attack, there is the end diastolic pressure is normal, the perforating vessels are working perfectly, even the left ventricular wall is getting adequate blood supply. But during angina, there is reduced blood flow to the subendocardial zone or the ischemic tissue. This leads to decrease in blood flow and development of angina because of decreased blood flow. Stable angina is generally relieved with drugs or rest that reduce the myocardial workload. Mechanism is basically imbalance of oxygen supply due to decrease in blood flow to the necrosed tissue. Constitutes about 90% of the angina cases. This is the most common one and the most important one. Next is the unstable angina or crescendo angina or acute coronary syndrome. When does this happen? It can happen at rest or with increasing severity for the last 1 to 2 months, or a new chest pain for less than 1 month. This is common where a thrombosis happens, rupture of an atheromatous plaque. So what happens when there is a rupture of a stable angina? In a stable angina, for example here, the atherosclerosis or atheroma is present in this coronary vessels. It's a stable angina. Now what happens? Suddenly it breaks off, leading to a thrombus. Now the thrombus ruptures from the atheromatous plaque and moves away. But this new area attracts platelet deposition, new platelet deposition. So the leading to progressive occlusion of the lumen. If you see here, the atheroma was of this size, but when the plaque is dislodged and new platelets keep getting deposited at the same site, the blood flow decreases even more because the lumen size decreases because of deposition of new platelets. Here if you see, at rest, the blood flow size or the diameter of the vessels are normal, but during exercise it increases. The resistance vessels also, the flow increases in normal times when you exercise. But in a classic angina case where there is atheroma, the flow does not increase because the atheroma takes up a lot of space inside the lumen. Unstable angina, whereas is considered a medical emergency because of the deposition of the platelets at the atheromatous plaque, the vessels keep getting narrow even more. So it might lead to even decrease in blood flow to the necrosed tissue, and also the emboli can get lost at a different site. Angina decubitus is another mild form. It's generally a nocturnal angina, occurs in recumbent position. It's not very much important. It's actually the fourth type. The third type is Prinzmetal's angina or variant or vasospastic angina. What happens here is, it's precipitated because of coronary artery spasm. Instead of a plaque or an atherosclerotic plaque, what happens here is, during spasm the flow decreases because the lumen of the blood vessels narrows down even smaller. So it's generally localized and occurs at rest or during sleep, and is not related to exertion or exercise, and it is not relieved by rest. Sometimes what happens, along with the spasm, if there is any atheromatous plaque is present, another stenosis also occurs. So double impact. So it deteriorates into unstable angina. If you see the photos here, this is a normal coronary artery with no atheromatous plaque. In a stable angina, what happens? Atherosclerosis develops. In an unstable angina, what happens? A part of this breaks down and moves away as an emboli. Now here, platelets start getting deposited and narrows the lumen even further. This unstable angina might lead into a infarct, myocardial infarct, because total stoppage of blood flow. And in variant angina, there is coronary spasm. The blood vessels narrows down. And if sometimes atherosclerosis occur in this coronary spasm, it's even worse because there is already spasm, narrowing of the blood vessels, and if an atherosclerotic plaque is present, it even narrows furthermore. Now coming to management. Non-medical management are the lifestyle modification. Obviously diet. Diet includes reduction of fatty foods, smoking cessation, physical exercise, reduction in, if obesity is present, reduction of weight. Now coming to the anginal drugs. History of anginal drugs, just the nitrates, amyl nitrate and nitroglycerin were found to provide instant relief from angina in 1800s. Those were the first drugs. The nitrates were the first drugs that were developed and provided to mankind. Subsequently, many other vasodilators were introduced, but many of them were found to be not very useful in angina, and most of them were compared with placebo and were found not to be better than placebo. But late in the 1960s and 1970s, beta blockers, especially beta 1 selective, cardio-selective beta blockers and calcium channel blockers came into the market, which are used nowadays for prophylaxis of angina. Nitrates are, next slide will help you with that. So first, coming to the clinical classification, as I said, there are two types of classification. One is the clinical classification and another is the pharmacological classification. Clinical classification are basically the drugs used to abort or terminate an attack. Angina has started, you give the drug to relieve the patient from the pain and abort the attack, anginal attack. So the drugs used are organic nitrates, can be of two types, rapid acting or rapid onset short acting are GTN, and slow onset long acting are isosorbide dinitrate or isosorbide mononitrate. Next, these are the drugs which are available to mankind since 1800s, the previous slide. Now these are the drugs used for chronic prophylaxis, prevention of any angina. These drugs came into the market in the late 1960s, 1970s. Firstly are the calcium channel blockers. It could be DHPs and non-DHPs. Most drugs used are amlodipine and clinidipine nowadays. Next are the beta blockers, especially cardio-selective beta blockers. Why? Why cardio-selective beta blockers? What will happen if you give alpha? Okay, we'll discuss this in the slides of beta blockers. Beta blockers, especially cardio-selective beta blockers like metoprolol, bisoprolol, atenolol are used. Potassium channel openers like nicorandil, cytoprotective drugs like ranolazine, bradycardic drug which reduce the heart rate is Ivabradine. Now few other additional drugs that are used, not directly related to angina, but antiplatelet drugs like aspirin, clopidogrel to decrease the chances of platelet aggregation, or statins, rosuvastatin, atorvastatin, hypolipidemic drugs, so that chances of atherosclerosis decreases. Now the classification, pharmacological classification, you can mug it up from your KDT, and do mug it up because this is the first thing asked to you during your vivas, and also if it comes for LAQ, at least you will be able to mention the drugs. So firstly are the nitrates, which according to the clinical classifications are given generally to abort an attack, also sometimes for prophylaxis. This could be of two types, short acting and long acting. Short acting like GTN, long acting isosorbide dinitrate, mononitrate. Beta blockers, cardio-selective beta blockers, calcium channel blockers. Next is potential channel openers and other anti-anginal drugs. We will discuss each of them in the next slide. First and the most important, this comes as an LAQ, are the nitrates. Okay. Nitrates generally are of two types, as seen in the last slide, short acting and long acting. Firstly, let's discuss the short acting ones, glyceryl trinitrate or nitroglycerin, NTG. You have seen, if you have grandparents, you have seen some of them taking tablets sublingually for to relieve the chest pain. So this is the drug, GTN. It's a very old drug. Their main mechanism of action is direct smooth muscle relaxation. How does it do? The nitrates, now if you see in this photo, the nitrodilators, the nitrates when given to a patient, they get denitrated, which releases nitrous oxide into the cell. This is the reason these drugs are also called as NO donors, nitric oxide donors. Now the NO released, it activates the cytosolic soluble cGMP, guanyl cyclase, which leads to increase in cGMP availability inside the cells. Now what happens when there is increased availability of cGMP in the cells? It causes dephosphorylation of MLCK. What happens? MLCK is dephosphorylated into MLCK-P or reduced phosphorylated MLCK. Now what happens when phosphorylated MLCK is available inside the cells? It inhibits the activation of myosin or phosphorylation of myosin. So what happens? There is no interaction between myosin and actin. Thus, there is no contraction, leads to relaxation of the blood vessels or the smooth muscle, and ultimately leading to relaxation of the blood vessels. Another action, this raised intracellular cGMP which is available, it reduces the calcium entry into the cells, thus again helping in relaxation of the smooth muscles. Also, because of the NO donor or nitrous oxide release, it has mild anti-aggregatory action on the platelet. Please mug up the classifications and understand this mechanism of action. If you understand it, it's very easy. Using this diagram, when you read it, read the mechanism of action, read it using this diagram which is available in your KDT as well. It will help you understand the mechanism of action rather than mugging it up. Now, the pharmacological actions, how the nitrates work are by three methods. It's preload reduction, afterload reduction, and dilatation, redistribution of the coronary blood flow. So, first, the preload reduction. Nitrates dilate the veins more than the arteries, more venodilation. So, what happens? Peripheral pooling of blood happens. If peripheral pooling of blood happens, there is decreases in venous return to the heart. What will happen if there is decreased venous return? It decreases the preload on the heart. Thus, decreasing the preload on the heart leads to decrease in end diastolic size and pressure. Now, if there is decrease in end diastolic size, this leads to decrease in cardiac workload. How does it decrease the cardiac workload? According to the Laplace relationship or Laplace equation. What is Laplace equation? Cardiac workload is equivalent to ventricular diameter and ventricular pressure into ventricular pressure. Now, the afterload reduction. Nitrates, what they do? They of course dilate the veins but also dilate the arteries. Veins dilation is more than the arteries, but it also dilates the arteries. So, there is some arteriolar dilation. So, what happens when there is arteriolar dilation? There is decrease in peripheral resistance, or afterload on the heart is decreased. The work required to pump the blood by the heart is reduced. So, there is fall of BP because there is decreased afterload. Systolic is more reduced than diastolic because the heart has to work less to pump the blood into the peripheral circulation. So, there is reduction in cardiac work which is directly proportional to the aortic impedance. But main action of nitrous oxide is the preload reduction. Second is the afterload reduction. Now, what happens in the coronary supply? There is redistribution of coronary flow. In the ischemic zone, there is redistribution of blood by dilatation of the epicardial coronaries and collateral vessels in the heart. So, this redistribution of blood happens in the ischemic zone so that the ischemic zone gets blood supply from other blood vessels. In the non-ischemic zone or resistance vessel maintain the tone, there is no increase or decrease in flow as a compensation. If you see this diagram, there is an atheroma present in this conducting vessel, there is ischemia happening in this part. Ischemic dilatation has happened in the subendocardial resistance vessels. Now, when you give nitrates, there is dilatation of this coronary vessel, so increased blood flow happens. Flow increases in the ischemic zone, but in the non-ischemic zone, there is no dilatation. Resistance vessel in non-ischemic zone maintains tone. Now, the effects on heart and other organs. In the heart, there is no direct stimulant or depressant action. It dilates the cutaneous vessels, so flushing happens. It dilates the meningeal vessels, so headache might happen. Splanchnic and renal blood flow decreases to compensate for vasodilation of the other areas. It also decongests lungs by shifting blood from systemic circulation. Now, it is a smooth muscle relaxing. So, other smooth muscles also gets relaxed. Bronchi, biliary tract and esophagus are relaxed. So, any use you can think of from this action? biliary colic, esophageal spasm is also relieved with nitrates. Intestine, ureter, uterus, the effects of nitrates on these are variable and insignificant, you can ignore. On the platelets, because nitrous oxide is generated from the nitrates, it activates cGMP, a production in the platelets, so mild anti-aggregatory effect on the platelets as well. So, this is the reason it is valuable in unstable angina. Pharmacokinetics, all nitrates are lipid soluble, so well absorbed through buccal mucosa, skin, intestine. That's why it's mostly given sublingually, also available as transdermal patches and can be taken orally. All have extensive first-pass metabolism except isosorbide mononitrate. So, isosorbide dinitrate and isosorbide mononitrate are the same drugs. Mononitrate is the active metabolite. So, it does not undergo any first-pass metabolism. Adverse effects are mainly due to vasodilation. So, what will happen? One is hypotension, postural hypotension, palpitations, headache, flushing, weakness, dizziness, fainting, all because of hypotension. Other adverse effects mainly are methemoglobinemia, because nitrite oxidizes ferrous into ferric. We will discuss one of the reasons, one of the other uses of nitrites in cyanide poisoning is because of this adverse effect. We will discuss in the next slide. Few effects: tolerance. Nitrates on taking long time, tolerance develop. If continuously taken every day, tolerance develops and you have to increase the dosage. So, the better way is to wean off within hours for a drug-free period. So, it is always advised when you are giving nitrates for a long time, give a drug-free period every day. So, generally for GTN it is advised don't give it after 6 p.m. or isosorbide after 3 p.m. so that there is a drug-free interval that the patient gets. Dependence. Sudden withdrawal after prolonged exposure can lead to spasm of coronary vessels and peripheral blood vessels, leading to symptoms of hypertension or precipitating angina. Now, Monday morning sickness. This is a very classical example of GTN or nitrates. What happened was, during the 1960s, the workers in the nitrite factory, they used to develop angina-like symptoms or headache on Monday morning. Why is it used to happen? During the week, when the worker in that factory is getting exposed to nitrates for the period, maybe Tuesday, Wednesday, the patient develops tolerance. So, there is no effects of the nitrates on the patient on the weekend or till Friday when he is getting exposed. But Saturday, Sunday, when the factory is closed and there is weaning off of the GTN or nitrites in the workers, they used to be relieved. But when they come back on Monday morning, again on sudden exposure to glycerol, trinitrate or any other nitrates, the effects of nitrates develop and the the workers complained of chest tightness, headache, nausea, vomiting, etc. This is known as the Monday morning sickness. Sometimes I asked you in Viva. Now, coming to individual nitrates, GTN, it's a volatile liquid stored in airtight glass containers. It's not stable in plastic containers and amber colored bottles to prevent it from degradation due to sunlight. Sublingually given, acts within 1 to 2 minutes and affects peaks 3 to 6 minutes, effect stays for around 30 minutes. Transdermal patches give steady delivery over 24 hours, but there are chances of development of tolerance. Acts in 60 minutes, fades after 8 to 10 hours due to tolerance, development of tolerance. Oral sustained release preparations are given for chronic prophylaxis. IV is used generally for an angina or an MI, rapid steady titrable plasma concentration for as long as desired. When there is an angina attack, not relieved with sublingual tablets. Now, few examples of GTN that are available in the market. This is GTN tablets for sublingual use. This is a GTN spray for again sublingual use. GTN transdermal patches for skin patches. Now, other longer acting individual nitrates like isosorbate dinitrate and isosorbate mononitrate. This is the active metabolite of isosorbate dinitrate, so doesn't undergo fast metabolism. It peaks in 5 to 8 minutes. For sublingually, it's for acute attack 5 to 10 mg is given, again repeated after 15 minutes. Oral for chronic prophylaxis 10 to 20 mg. Mononitrate has a longer T-half and better bioavailability because it's the active metabolite. Isosorbate dinitrate last dose not after 6 p.m. and mononitrate last dose in the afternoon. Extra tablet only given OD in the morning because to prevent development of tolerance. Other few longer acting drugs which are not very commonly used are erythritol tetranitrate and pentaerythritol tetranitrate, but rarely used nowadays. The most common drugs used are GTN, isosorbate dinitrate and isosorbate mononitrate. Pharmacokinetics, this graph shows, the red one shows the onset of action and the blue one duration of action. So, NTG or GTN when given sublingually starts acting in within 2 minutes and works for almost 25 to 30 minutes. Whereas when given orally, it starts acting in 35 minutes and works for 4 to 8 hours. And transdermal patches starts working again in 30 minutes and works for 10 to 12 hours. Similarly, isosorbate dinitrate given sublingually works faster. That's the reason in case of acute attack of angina, your patients are asked to take sublingually. Uses of nitrates, of course, angina pectoris, acute coronary syndrome, myocardial infarction, congestive cardiac failure or CHF, and acute left ventricular failure, and in hypertensive emergency as well. Nitrates are not to be administered when systolic BP is less than 90 mm or heart rate less than 50 or more than 100. Right ventricular infarction is suspected and patient has taken sildenafil within the past 24 hours. It can lead to severe hypotension and fall in BP, and sometimes it has also led to MI. Non-cardiac uses, biliary colic, esophageal spasm, as I mentioned before, because it's a smooth muscle relaxant, so helps in biliary colic and esophageal spasm. Now, cyanide poison because of methemoglobinemia. One of the adverse effect of using nitrates is methemoglobin formation with nitrate. So, when in a normal patient, when nitrite is given, it forms methemoglobin. If there is cyanide poisoning present, what it causes? Cyanide mixed with methemoglobin, forming cyanomethemoglobin. Now, if sodium thiosulfite is added, it releases methemoglobin and sodium thiocyanate. It's a stable compound and is excreted with urine and is non-poisonous. So, this is the reason GTN can be used or any nitrates can be used in cyanide poison, but better drugs are available nowadays, so hardly used. Sodium nitrate is a very weak vasodilator, so it can be used in large volumes. GTN or isosorbate dinitrate, they are stronger nitrates, not used in cyanide. Next are the beta blockers. As I mentioned, cardio-selective beta-1 blockers are preferred like bisoprolol, metoprolol. Beta-1 blockers are preferred, bisoprolol, atenolol or metoprolol. Non-selective because this may worsen, non-selective is not used because they may worsen variant angina due to unopposed alpha receptor mediated coronary constriction. That is the reason always cardio-selective beta-1 blockers are advised. So, blockade of beta-1 receptors on heart leads to all negative action, decreased force, decreased rate and decreased conduction. So, there is net reduction in oxygen requirement. So, beneficial for the heart. Long-term treatment with beta blockers. So, these are all drugs used for prophylaxis or prevention of angina or IHD. So, decreases risk of sudden cardiac death and prolongs life expectancy in coronary artery disease patients. Next are the CCBs. CCBs are of 3 types: phenylalkylamine like verapamil or benzothiazepine, diltiazem. These 2 are commonly called as non-DHPs, and the DHPs are nifedipine, amlodipine, clinidipine, nicardipine. Various drugs are available. DHPs are generally long-acting, especially amlodipine. Nifedipine is a short-acting DHP. preferably avoided in angina patients. Now, mechanism of action of CCBs. CCB is a calcium channel blocker. It binds to alpha 1 subunit of L type of voltage sensitive calcium channels, thus inhibiting the calcium entry into the cells. There are 3 types of calcium channels. What are the 3 types? L type, N type and T type. CCBs, most of those drugs binds to alpha 1 subunit of the L type. Few CCBs also act on the N type apart from L type. So, pharmacological actions on the cardiac tissue are again negative inotropic, negative dromotropic and negative chronotropic. And on the vascular smooth muscles, relaxes all smooth muscles. Maximum action is on the arteriole, so decreases the afterload or decreases the total peripheral resistance due to arteriolar dilatation. Now, adverse effects of CCBs, palpitations may occur. This is mainly with the DHPs because there is rapid vasodilation, reflex stimulation of the sympathetic system. But these things does not occur with longer acting DHPs like amlodipine or clinidipine. Flushing and hypotension again due to fall in BP, headache, nausea. Now, one of the major side effects with using calcium channel blockers, especially amlodipine, etc., are ankle edema. A patient comes with pedal edema, ankle edema. This pedal edema is not due to fluid retention, it occurs because there is greater dilatation of the precapillary than the postcapillary. So, decrease in blood return, venous return. Now, uses CCB is the most common use is hypertension, angina, cardiac arrhythmias, CHF, CCP. Nifedipine, there is another mild indication is alternative drug can be used in premature labor, but rarely used. Now, CCBs in angina, never use short-acting DHPs like nifedipine. It can worsen the situation. Long-acting DHPs like amlodipine or clinidipine can be given. Chances of reflex tachycardia are less. Verapamil, diltiazem are also preferred. They decrease the afterload and directive negative action on the heart. This is how the CCBs act during angina and also for the prophylaxis for any CAD or IHD. Now, next are the potassium channel openers like minoxidil and diazoxide. They are used in hypertension. One more drug is nicorandil. They opens the ATP sensitive potassium channels, causes hyperpolarization. So, there is smooth muscle relaxation and vasodilation. Also a nitrous oxide donor, so venodilation. So, this decreases both afterload and preload, decreases oxygen requirement. Mild coronary dilatation also happens and it helps. And there is a cardioprotective action by stimulating the ischemic preconditioning. How does it happen? The tissue is rendered resistant to the deleterious effects of prolonged ischemia by previous exposure to brief periods of vascular occlusion. So, cardioprotective action of potassium channel opener is by stimulating ischemic preconditioning. Now, glibenclamide. Glibenclamide is a drug for type 2 diabetes mellitus. It is a potassium channel blocker. So, if these two drugs are given together, mostly there are a lot of patients of metabolic syndrome who have diabetes and also comes with angina. If these two drugs are combined, none of them will act because of they interact with each other. Now, this nicorandil has a good oral absorption, complete metabolism in the liver, excreted in urine. This drug follows biphasic elimination. So, when the drug concentration is higher, in the beginning there is rapid elimination, the T-half is 1 hour, rapid elimination in the first 1 hour. Then, when the plasma concentration falls below, then the T-half is around 12 hours. Slowly it is eliminated from the kidney. So, when there is the concentration in the plasma is high, there is rapid elimination, and when the concentration falls, it slowly excreted. Adverse effects are again what's because of hypotension, flushing, palpitation, headache, dizziness. One common adverse effect with nicotinamide and is a reason for stopping the drug is large painful aphthous ulcer or mouth ulcers. This drug also interacts with sildenafil, which is a PDE inhibitor, can cause severe hypotension and can also precipitate MI in some patients. Now, one drug which is not used nowadays is dipyridamole, but important for you because I'll tell you, because of this coronary still phenomenon. Most of the time during Viva, it's asked what is coronary still phenomenon and which drug causes it. Dipyridamole is another anti-anginal drug which is a coronary artery dilator and inhibits platelet aggregation. So, there is increase in total coronary flow, dilates the resistance vessels. No effect on conducting coronary vessels. What is coronary still phenomenon? It's diverse blood from ischemic to non-ischemic zone. If you look at this diagram, this is the atherma conducting vessel. There is decreased blood supply to the ischemic area. Now, this is the B1 is when nitrates are given. There is increase in there is dilatation of the conducting vessel, so more blood flow, and blood flow increases to the ischemic zone, and in non-ischemic zone the resistance vessels maintain tone. So, no increase in blood flow to the non-ischemic area, but to the ischemic area there is dilatation. So, beneficial effect. This happens with nitrous oxide, GTN or any nitrate. But what happens with dipyridamole is there is no dilatation of the conducting vessel and flow decreases in the ischemic zone and dilates in the non-ischemic zone. So, instead of beneficial effect, it causes the coronary still phenomenon, decreases blood flow to the ischemic zone and increases blood flow to the non-ischemic zone. So, it does not improve, though theoretically or pharmacologically this drug is a very good, could be a good prospect for angina, but because of this coronary still phenomenon, it's not useful and thus not used nowadays. So, coronary still phenomenon sometimes asked you in the Viva, do remember. Other anti-anginal drugs are trimetazidine. It's a non-hemodynamic mechanism, mainly no effect on the oxygen consumption, more on the oxygen fatty acid oxidation. Its modulus myocardial metabolism improves tolerance to ischemia. It's actually a partial fatty acid oxidation inhibitor. It inhibits mitochondrial LC3-CAT, long channel 3 ketoacyl CoA-thiolase. It's the enzyme for the fatty acid oxidation. Basically, it's a partial fatty acid oxidation inhibitor, pathway inhibitor. So, decreases fatty acid oxidation, more oxygen required for fatty acid oxidation, thus reduces the oxygen need and also increases glucose oxidation. Therefore, oxygen demand is decreased with using trimetazidine. Side effects are gastric burning, dizziness, fatigue, muscle cramps, reversible Parkinsonism in elderly. Used in various countries but not used in UK or USA. It's available in India but rarely used where other drugs are contraindicated. Ranolazine is again a sodium current channel inhibitor. It inhibits the late sodium channel currents normally required for sodium calcium exchange. So, thus decreases the intracellular calcium levels. Decrease in calcium overload decreases contractility of the cardiac muscles, thus a cardioprotective effect. It also inhibits the LC3-CAT pathway, thus partial fatty oxidase inhibitor. PK is around 4 to 6 hours for oral absorption, bioavailability 30 to 50%, metabolized by CYP3A enzymes, thus not to be taken by patients taking other CYP3A4 inhibitors, but there is no interaction with sildenafil, can be safely given on patients taking sildenafil or tadalafil. Side effects are dizziness, constipation, postural hypotension and QT prolongation. Next is the last drug is Ivabradine. It's a pure heart rate lowering drug, decreases the heart rate, blocks cardiac pacemaker cells, the F channels or the funny currents, opens during the early slow diastolic phase, depolarization, blocks the funny currents, decreases heart rate, decreases oxygen demand, thus having a cardioprotective action. Prolonged diastole also improves myocardial perfusion, thus increasing oxygen supply to the myocardial tissue. T-half is around 2 hours. Side effects: excessive bradycardia or prolonged PR interval. Sometimes visual disturbances are found on using Ivabradine for a longer period. Contraindication: heart rate less than 60 minutes because it's a pure bradycardic drug. So, it will heart rate will fall even more. Uses are chronic stable angina. Patients who are beta blocker intolerant, maybe asthmatic patients, or in other contraindicated patients. Sinus tachycardia, stable grade 2 to grade 4 heart failure. Now, drug combinations that are used in angina. Aim of the therapy is symptomatic treatment, relieving the pain, modifying the course of coronary artery disease, and cardioprotection. Drug of choice depends on stage and severity of the disease, associated other conditions, other metabolic conditions, other diseases, individual accessibility of side effects. Drug combinations used in angina are monotherapy. Firstly, when monotherapy fails, nitrate plus beta blocker. This is the most preferred combination, rational combination in classic angina. The other option is CCBs, mainly DHPs, preferred are amlodipine or clinidipine with beta blockers, cardio-selective beta blockers in classic angina. But for vasospastic angina, nitrates with CCBs are preferred. 3 drug combinations can be used when 2 drug therapy is failing, then nitrates, CCBs and beta blockers are combined. But verapamil or diltiazem, which are non-DHPs, non-DHP CCBs are never to be used with beta blockers. It can lead to heart block. And remember this, non-DHPs, verapamil and diltiazem never to be used with beta blockers. Next, this is just the classification of drugs used in PVD. You can just mug up the classification. Classification is all you need. In depth, not required. Now, coming to the second part of the class, which is how to manage a case of MI or IE. So, we have been through this. How does angina feel like? Chest pain. Symptoms mainly prolonged cardiac pain, chest pain in the throat, radiating to throat, arms, epigastrium, anxiety, nausea and vomiting, breathlessness, collapse or syncope. Physical signs, generally signs of pallor, sweating, tachycardia, signs of vagal activation, bradycardia or vomiting. Signs of impaired myocardial function, hypotension, cold peripheries, narrow pulse pressure, raised JVP. Third heart sound is heard or quite first heart sound. Low grade fever, complications like mitral regurgitation or pericarditis might occur. Lung crepitations is also one finding you see on a long term patient who are not treated. Pathology and the clinical problems. Stable angina, as you know, is due to fixed arteriovenous stenosis of one or more coronary arteries. Unstable is when there is a plaque rupture, emboli happens, superimposed with thrombosis, platelet deposition. Myocardial infarction. Necrosis happens when acute occlusion of a coronary artery due to plaque rupture or erosion, or with long-term ischemia. Heart failure, arrhythmia, sudden death are all related to this coronary artery diseases. This is a photo of the stages of 6 stages of atherosclerosis. Type 1 to type 4 are generally clinically silent. Type 4 sometimes some symptoms might be present. This, if you see how the fatty development happens in the tunica intima of the blood vessels. Type 5 and type 6 are the complicated ones where thrombosis happens, atherosclerosis happens, and patients generally come with symptoms. Now, this is a photo where the time course of myocardial infarction, if you see how this brown color shows the infarction which develops with time passage. So, and yellow part is the ischemia. Ischemia, if it's reversed and timely treated with nitrates or PCI, can be reversed, and if the patient is not treated timely, it might lead to infarction and a non-reversible damage to the coronary tissue. This is a guidelines on how to treat a patient. You will generally see in medicine when a patient comes with complaints of chest pain, you analyze, take history, see for a X-ray and a 12-lead ECG. If there is STEMI present, definitely go for treatment. If PCI, if STEMI is present, PCI or fibrinolytics are given. Basically this will be covered in your medicine lecture. ECG changes is STEMI. This is the immediate finding which is found acute ST elevation, which is also called as STEMI. I'll move to next the biomarkers. These are the biomarkers which gets elevated when a MI happens or CADs, coronary occlusion. Troponin T or troponin I. Creatinine kinase is the one increases in the first few hours. LDH increases after 72 hours. AST also increases slowly. So the during diagnosis, the most useful biomarkers in the immediate period are creatinine kinase and troponin. Now coming directly to drug therapy in MI. Firstly, the patient complains of severe pain. This is very important. This comes for your practical as well as short note in your theory. First, patient comes with severe chest pain and along with that anxiety and apprehension. So, first the drug given is GTN, 0.4 mg or 0.3 mg sublingually given every 5 minutes. Even after, if there is no relief after 3 doses of GTN, then you give opioids, morphine or pethidine to relieve the pain, the anginal pain. Also diazepam and antiemetic to reduce the apprehension. Sometimes diazepam and other alprazolam etc. are used, barbiturates or benzodiazepine to relieve the anxiety. Next is moist oxygen for oxygenation. Maintenance of blood volume with slow IV saline or dextrose infusion, but volume overload to be avoided. Check for the blood pressure. Correction of acidosis with IV sodium bicarbonate infusion. Prevention of and treatment of arrhythmia. Beta blockers are given IV or oral. If there is tachyarrhythmia present, then drugs like lidocaine, procainamide, amiodarone are given to reduce any tachyarrhythmia. And if there is bradycardia or heart block, adrenaline, atropine or electrical pacing are done. Next is, if there is pump failure, to increase the cardiac output and decrease the filling pressure, furosemide, GTN, dopamine, all inotropic drugs can be used. Furosemide is given to reduce the blood pressure. And next is prevention of thrombus extension, embolism or venous thrombosis. As you know, antiplatelet drugs like aspirin 75 to 150 mg are given preventively. Also clopidogrel can be a good alternative add-on and are now used. If STEMI is confirmed, generally aspirin, clopidogrel both are given. Anticoagulants are sometimes given heparin or enoxaparin IV, followed by they are given, patients are kept on oral anticoagulants like warfarin to prevent any DVT, deep vein thrombosis or arterial embolism. Next is thrombolysis and reperfusion. Fibrinolytics are given within 1 to 2 hours of MI symptom onset. That is the reason it's proactively told in symposiums that when the chest pain or angina starts, report to the hospital in that golden period. That first 1 to 2 hours is very important. Fibrinolytics like alteplase, ritaplase, tenecteplase can be given in STEMI or high risk non-STEMI cases. PCI with stenting is the preferred procedure, but depending the patient comes to the ER or the hospital within the first 4 hours. PCI is percutaneous intervention, generally coronary angiography, balloon therapy, stenting, these are all PCI. Next is prevention of remodeling and subsequent cardiac congestive heart failure. AC inhibitors and ARBs have been proven to decrease prevention of remodeling. And for prevention of future attacks, antiplatelets are given, aspirin, clopidogrel, to prevent any thrombus. Beta blockers are given to decrease the effect, cardio-selective beta blockers decrease the cardiac action or decreasing the workload of the heart. Hypolipidemics like statins are given to reduce cholesterol or triglyceride. Now other non-medical measures: do not smoke, do exercise, maintain the ideal body weight, eat a mixed diet rich in fruits and vegetables, have antioxidants like L-arginine and everything. L-arginine is an antioxidant, helps in NO donor. These are the strategies. Generally the questions asked in your exam are anti-anginals or nitrates, mechanism of action, and also this treatment of MI and ISD.